Hello, my name is Darren Hill, and this is Extracorporeal Membrane Oxygenation in Traumatically Injured Patients. A variety of trauma patients, including those suffering blunt thoracic trauma and penetrating thoracic trauma, do progress to refractory acute respiratory distress syndrome, or ARDS. Conventional ventilator management somewhat frequently fails in supporting these patients. Extracorporeal membrane oxygenation, or ECMO, is a viable option to support respiratory function in patients with ARDS. While used occasionally at Lancaster General Hospital, ECMO is not routinely used for the treatment of refractory ARDS and trauma patients. Recent publications, although non-conclusive, do demonstrate that the use of ECMO in ARDS of non-infectious origin, including trauma patients, can improve patient outcomes. Kim et al. Report that ECMO is associated with a high survival rate in patients with ARDS of non-infectious origin. That was in 2017. The purpose of this presentation is to discuss some recent reports regarding the use of ECMO in traumatically injured patients with refractory ARDS. PICO question is, does the use of ECMO in adult trauma patients exhibiting refractory ARDS improve survival to discharge rates compared to traditional lung protective ventilator management strategies? Elements of this: the population is the adult trauma patient exhibiting refractory ARDS. The intervention is the use of ECMO for ventilatory and respiratory support. The comparison is traditional lung protective ventilator management and medical support. And the outcome is survival to discharge. The literature search, the initial search was performed on Google Scholar with keywords extracorporeal, membrane, oxygenation, and trauma. This returned approximately 31,900 results. Subsequently, the Pennsylvania College of Health Sciences Library Discover Summon tool was utilizing the same keywords. The search was refined, narrowed to full text online only, results published in the last 5 years, scholarly and peer-reviewed articles, and journal articles. That narrowing returned approximately 1,800 results. The results were varied. Not all studies found included trauma patients as the primary population of study. Studies that were single patient case studies were vetted out, and additionally, results that did not include trauma patients as the primary study group were vetted. The aim for the chosen studies was a sample size that was larger than one patient, preferably from a variety of types of trauma, and when possible, participants who were treated in an established ECMO program, though this was not a requirement because few studies are actually performed in facilities that have a dedicated ECMO unit. Articles were also chosen that had similar inclusion criteria, mainly patients who were treated with traditional medical management and lung protective ventilator strategies first, who exhibited attributes of severe ARDS that were refractory to this management. In the 5 identified research articles, there are a number of noted similarities and differences. Similarities included a retrospective study design, small population sample sizes, generally pulmonary indications for ECMO, including ventilator perfusion ratios or PF ratios of less than 125, and generally studies showed positive patient outcomes in regards to survival to discharge. The articles also showed some differences. Some studies took place in established ECMO programs, while some took place with variable ECMO management. There were also some variability in the survival to discharge estimates. In discussing ECMO in the trauma patient, it's important to identify indications for ECMO therapy. Currently, ECMO is regarded as a salvage therapy in trauma patients suffering from ARDS who are unable to be managed using traditional ventilator and medical management. 3 of the 5 articles identified were retrospective studies in 1 or 2 medical centers. The authors identified similar inclusion criteria for patients requiring ECMO. These included patients with severe ARDS with persistent hypoxia despite maximum mechanical ventilatory support, that was Boussarge in 2015. A PF ratio of less than 125 with a plateau pressure of greater than 30 centimeters of water, that was Menaker et al. In 2018, and partial arterial oxygen pressure to fractional inspiratory oxygen concentration ratio less than 100 with an FiO2 of 1.0 or 100% oxygen, and high level positive end expiratory pressure or PEEP, that was Kim et al. In 2017. From these studies, it's possible to draw the conclusion that patients with ARDS refractory to traditional medical and ventilatory management are candidates for ECMO therapy. One of the key differences between the chosen studies is whether the study was performed in an established or a non-established ECMO program. Established ECMO programs had dedicated ECMO units on which interdisciplinary teams dedicated to management of ECMO patients rounded daily, and treatment protocols were established and maintained throughout the sample population. Programs with non-established ECMO management protocols may have had variable ECMO management protocols and modalities. Of the established ECMO program articles, reported survival to discharge rates were 78% and 55% respectively. In non-established ECMO programs, survival ranged from 35.7% to 52%, though these results may have somewhat biased reports based on the type of study performed. One study included all patients with non-infectious causes of ARDS, but of that population, only 9 patients were actually trauma patients. Of note, though, this study did demonstrate no statistical significance between the outcomes of trauma and non-trauma patients. The study performed by Hu et al. In 2019 was a retrospective database review performed by a national database. This study had a much larger sample size than other studies, but it's almost impossible to determine whether the percentage of treated patients were actually treated in an established versus a non-established ECMO program. From this data, it's possible to conclude that having an established ECMO program is not necessarily a determining factor in improved survival to discharge in those trauma patients treated with ECMO therapy. Although the established ECMO programs return survival rates greater than 50%, and one study demonstrated a lower survival rate, the larger study population included in this review demonstrated a greater than 50% survival rate as well. There are some challenges in synthesizing the data from the selected articles. While it's been established that all studies included patients in severe acute respiratory distress syndrome, samples in these studies had variable mechanisms of injury. April et al. Included multiple traumatic injuries from motor vehicle crashes to burns. Menaker et al. Included post-traumatic ARDS, bacterial pneumonia, aspiration, and pneumonectomy. Kim et al. Included near drowning, drug intoxication, MVA, falls, and gunshot wounds. And Hu et al. Included all patients with an ICD-9 code for injury and an ICD-9 procedure code for ECMO. So definitely some varied inclusion criteria for these trauma patients. Variable mechanisms of injury may have skewed some of the results, and further studies for specific types of traumatic injury and outcomes will be necessary for a more concise synthesis. Variable ECMO management is also a challenge when attempting to synthesize the data. To date, ECMO management is facility dependent, although ECMO management recommendations exist. As ECMO therapy in trauma patients is not currently a standard of practice, there are no standardized treatment modalities. Because of this lack of standardization, outcome measurements for patients treated in different facilities may be skewed by the quality of ECMO management in that facility. This is particularly important in the identified studies, as the majority of them are single center studies that may have unique ECMO management. Until there is some sort of a standardization of management of ECMO for trauma patients, survival estimates may have a pretty substantial bias. Of the 5 articles reviewed, a common theme is that ECMO in trauma patients with refractory ARDS is a viable treatment modality. Based on the article review, the recommendation is simply to increase the use of ECMO in traumatically injured patients who progress to refractory ARDS with a PF ratio of less than 125. ECMO use is increasing. According to Hu et al., 62% of patients treated with ECMO were treated between 2011 and 2016, while 48% were treated between 1989 and 2010. Part of this increase in therapy use may be related to increased utilization of ECMO during the H1N1 pandemic. Despite this, the reviewed studies show modest to good survival rates in patients treated with ECMO therapy. ECMO is a viable next step in the management of trauma patients with refractory ARDS who may otherwise not survive with traditional ventilator and medical management. There are some challenges to consider with the increased implementation of ECMO in traumatically injured patients with refractory ARDS. To date, Lancaster General Hospital does not perform ECMO therapy, or does perform ECMO therapy, but does not have an established ECMO program with ECMO trained nurses and a dedicated intensivist ECMO team rounding with established ECMO management protocols. Additionally, trauma physicians do not currently command the use of ECMO, and this is deferred to cardiothoracic intensivists. The trauma neurosurgical ICU does not currently have the capacity to manage ECMO patients. When ECMO is established, it is necessary to transfer the patient to a cardiac intensive care unit. This transfer removes the trauma intensivist from direct oversight of the patient. While it's not necessarily a change in patient management, as the physicians can round in another unit, it does incur some comfort aspect in the care of these patients and may pose a challenge in initiating and sustaining some increased ECMO efforts. Also, despite some evidence supporting the use of ECMO in traumatically injured patients with refractory ARDS, there's still no definitive evidence stating that survival is improved compared to traditional medical management. Efforts made to manage these patients may still be considered experimental, and although there is evidence to support the use of ECMO in trauma patients, complications such as increased risk of hemorrhage and coagulopathy may deter implementation of increased ECMO utilization. In conclusion, trauma patients may be at an increased risk for developing non-infectious ARDS just based on mechanism of injury. ECMO therapy is a treatment option for these patients, these trauma patients experiencing refractory ARDS. There is some evidence that exists that support the use of ECMO in trauma patients with refractory ARDS, and these studies tend to have positive survival outcomes. Increased use of ECMO in trauma patients should be considered at Lancaster General Hospital, and it's important to note that further studies with standardized management protocols that are nationwide should be performed to further support the use of ECMO in traumatically injured patients with refractory ARDS. I've included the articles for reference. Thank you very much.